Now I'd like to call upon stage Dr. Priyanka Pansambal ma'am to present on rectum anatomy and role of MRI.
Good morning everyone. Rectum anatomy, I'll be emphasizing on the rectum anatomy and role of MRI in the rectal malignancies. Per se, colorectal cancer has been on the increasing verge. The development of the imaging modalities and the introduction of the new multimodality therapies has been increasing on the incidence, leading to the local recurrence rate and the other things. Going to the conventional anatomy, rectum begins at a level of S3 level as a continuation of the sigmoid colon. It is differentiated from the rest of the colon in the form of absence of tinea coli, hostra, and appendices evolucate. Though usually in the lower mammals, the rectum is straight. In our case, the rectum usually follows two curvatures according to the sacrum and coccyx. Two major flexures, the sacral flexure concavity anteriorly and rectal flexure convexity posteriorly. There are three lateral flexures due to transverse fold. Amongst them are the superior, intermediate, and inferior. Amongst them is the intermediate is the most consistent one. There comes the peritoneal reflections, defining the rectum into the upper, middle, and lower, defining their coverings, the rectovesical pouch and the rectouterine pouch, again depicting the conventional anatomy on the form of sacral flexure and the anorectal flexure. Depending on that, we have to define for the surgical point of view, the rectum is divided into the low, mid, and high, depending on the level from the anorectal junction, 0 to 5 centimeter, 5 to 10, and high 10 to 15 centimeter. Next, coming to the peritoneal cavity, the rectum is partially peritonealized structure. In the low rectum, it is entirely covered by the mesorectal fascia. In the mid rectum, the peritoneal cavity is seen only anteriorly, and the peritoneal cavity in the high rectum is anteriorly and towards the lateral aspect. Coming to the cross-sectional anatomy, the rectal mucosa is it is having two layers, submucosa, and the outer muscularis layer, which is longitudinal muscular layer and the circular muscular layer, continuing as the outer longitudinal layer continues as the internal sphincter. External sphincter is a striated muscle formed by the levator and the puborectalis ling. Coming to the lymphatic drainage, the primary stations for the lymphatic drainage are the inferior mesenteric and the middle rectal nodes. Inferior rectal nodes are the anorectal junction nodes. The first station nodes in the case of rectal malignancies are the obturator and the lateral iliac group of nodes. Coming to the nodes shown in the yellow ones are considered as the regional nodes for the rectal pathologies, including the mesorectal, superior rectalis, and the inferior mesenteric. The lateral group of nodes includes the obturator and the iliac internal. The ones shown in the red are considered as the distant metastatic nodes in the case of rectal cancers, which include internal iliac, external iliac, common iliac, and on the inguinal nodes. The surgical anatomy of point, the surgical differentiation between these two anatomy is there is difference between the anal verge. The surgical anal canal extends from the anorectal ling till the anal verge, and for the anatomical anal canal, it is a dented line between the anal verge. So basically, for all practical purposes, the rectum for the surgeons is divided into two main categories, into the upper and lower rectum. And now coming to the concept of the mesorectal fascia, like every bowel and like every rest of the colon, rectum has its own mesorectal fascia and mesorectal fat. It is a thin fibrous structure enclosing the perirectal fat surrounding the rectum. It begins at the rectosigmoid junction with the connective tissue of the sigmoid mesentery and extends to the endorectum at the levator. Laterally, it extends around the rectum, and perirectal fat becomes contiguous anteriorly with the rectovesical fascia and posteriorly with the presacral fascia. It encases the superior rectal artery and branches of superior rectal vein and its tributaries, including the lymph nodes. The MRI has plays important role in the staging the disease, in selecting and optimizing the treatment planning. MRI has become the most important for the local staging of the rectal cancer for both primary staging and restaging after the preoperative chemoradiation. It provides high accuracy for the depiction of the circumferential resection margin, which is the non-peritonealized portion of the rectum, which usually surgeon resects, and MRI is the most accurate imaging modality to determine the CRM. Then in that order, the T category and the nodal status in that order. It helps assess the resectability and decide between the sphincter saving or more radical surgeries. MRI technique, depending on that, Mercury group has defined as high resolution T2 weighted sequences in multiple planes with thickness of 3 to 5 millimeter are usually recommended. Patient preparation is usually not recommended unless and until we are dealing with the upper rectal cancers. Use of spasmolytics can be done. Endorectal feeling usually is not advised because it falls positively distance the rectum and obliterates the distance between the actual tumor and the mesorectal fat. Sometimes the distance from the anal verge is also has given the false positive reports. Preparative steps like microenema can be used in the restaging to avoid the gas into susceptibility artifacts for diffusion weighted imaging in the restaging phase. Cranial border of the field of the view should be at the level of the sacral promontory and at the caudal border below the anal canal. This is to include the metastatic group of lymph nodes at the level of S3 and the inguinal in the case of local infiltration. Axial series should be perpendicular to the tumor to allow the proper assessment of the extension to the tumor beyond the rectal wall. Now coming to the MR anatomy, the mucosa is depicted by the intermediate single intensity line. Submucosa is hyperintense and muscularis propria is depicted as a thin hypointense line. Usually the mucosa and submucosa differentiation can be only seen when there is a bulk amount of submucosal edema, else the rectum can be seen as a two-layered structures. Now coming to the anatomy. This we can see as a external sphincter, the muscularis propria going up ahead. This is the mesorectal fat containing the mesorectal vessels and the nodes. This thin T2 hypointense line is the mesorectal fascia. Coming on to the coronal anatomy, the levator ani forming the external sphincter with the puborectalis, the intersphincteric plane. This is more important for the lower rectal tumors, the internal sphincter formed by the outer longitudinal muscle. Coming to the sagittal anatomy. Now this we can see the sagittal anatomy, sagittal section should be covering from extremes to the side pelvic walls. Now this will be the peritoneal reflection. Usually peritoneal reflection is seen at the level of seminal vesicles in the male, at the level of, and in the females at the uterocervical junction. This thin hypointense line, if you can appreciate, is a peritoneal reflection defining the upper rectum, middle rectum and lower rectum. This is the rectovesical pouch, the intraperitoneal space and the extraperitoneal rectum has been shown. Why we are dealing so much with the rectal MR, and there is a difference between differentiating the rectal colon and rectal cancer and the colon cancer. Patterns of local recurrence in the rectal cancer are due to high rich lymphatics, drainage to the pelvic side walls. Colon cancer is low recurrence with the anastomotic recurrence not common. Distant recurrence is usually seen in the lung metastasis in the form of rectal cancer due to drainage along the superior rectal vessels, while in the form of colon cancer it is seen usually via the portal vein and it is a more peritoneal dissemination. Surgical approach will limit the surgical accessibility as surgery is completely considerable in the case of colon cancer. Benefits of RT and chemotherapy has been proven in the form of rectal cancer, and however they are guarded in the colon cancer. Due to that, there comes a concept of sigmoid takeoff. Sigmoid takeoff is a point where the fixated rectum ends and the mobile mesocolon begins. It is seen as a point where sigmoid colon taking ventral sweep on axial images and horizontal sweep on the sagittal images. Rectal tumor is defined as a tumor with its lower border of the tumor below the level of sigmoid takeoff, and the sigmoid tumor is defined as a tumor with its lower border situated above the level of sigmoid takeoff. We need to define this because, as we have already seen, there is a difference between dealing with the rectal cancer and the colon cancer. Here we can see the horizontal sweep and the ventral sweep defining the sigmoid takeoff. There comes the concept of surgical margins. Circumferential resection in usually till the eras of 1980s there was a concept of longitudinal resection margin. Then with the introduction of the MR, here comes the concept of circumferential resection margin, which is usually due to the circumferential resection margin, which is usually the resection of the non-peritonealized portion of the fat that is resected during the surgery. The TNM staging, we can like rectum being the hollow viscous invasion from the inside to outside wall, and adjacent structure defines its T staging. As we have seen, T1, T2 are related to the rectal wall. T3 is beyond the bowel wall, where comes the fascia, importance of the mesorectal fat and fascia. T4 is the invasion into the adjacent rectum. Then comes the NM staging. This is the lymphatic drainage. Then the evolution of surgeries has come. This is due to the depiction of the accurate local staging of depending on the MRI. Multimodality therapy has been advised for the locally advanced resectable cancers, long course of neoadjuvant CC therapy, short course radiotherapy, complete neoadjuvant chemotherapy, and upfront surgeries, followed by the report templates. There are a number of report templates available on the net. If you have a structured report template, you won't miss anything like tumor location, morphology, distance from the inferior border, relationship to the anterior peritoneal reflection, craniocaudal length, circumferential location. Then comes the T category. The report templates of the lower rectal tumors must include the invasion of the sphincter complex, the internal sphincter, intersphincteric plane, and external sphincter. EMVA and CRM are the two most important things. Coming to the few cases now. Now this, as you can see, there is a circumferential intermediate thickening along the posterolateral aspect of rectum with adjacent mesorectal fat standing. So this proved to be a T3 stage, though there is N1 nodes, we could see only few nodes. Those were not metastatic, proven on the PET CT. Now if we can see, this being the lower rectal cancer, the intersphincteric, the internal sphincter is involved, and intersphincteric plane is obliterated on the left side. So this patient will be posted first for a neoadjuvant CTRT, then that will be downstage, and again upfront surgery can be planned. Coming to a more metastatic disease, a large tumor involving the large polypoidal growth tumor involving the middle and lower rectum. And here we can see there is involvement of the anteroperitoneal reflection, multiple nodes are seen. So irrespective of the N or this staging, it will be labeled as T4 disease, as it will be involving the anterior peritoneal reflection. Then comes the EMVI, extramural vascular invasion, is usually a bad prognostic factor, as it will have a more hematogenous spread. It will have, in this case, a linear serpentinous structure with a tumor deposits of intermediate single intensity can be seen, which can be better related on the coronal set of images.
The rectal anatomy and its importance will be depending on if you follow the structure reporting template, rectal fat, rectal feature, and the CRM. Those are must to be included in your report. Thanks so much.
Thank you, ma'am, for such an amazing lecture. I'd like to request Dr. Malani sir to felicitate Dr. Priyanka ma'am.